Right. So let's start. So what I'll do in the next 45 minutes to 1 hour is I'll give you two talks. One is what's happening in bariatric endoscopy across the world. And the second pertaining to the endoscopic sleeve gastroplasty, which we are commonly practicing in few centers in India. And how to start if you want to start bariatric endoscopy in your respective units. And what are the tips and tricks of trade. So coming to bariatric endoscopy per se, as we all know, and you are a learned audience, especially the bariatric surgeons, the prevalence and of obesity in India, it's around 20% in male, 25 in female. Of course, with a little old census, probably it might have increased by now. And if not in any, we are competing with the USA in terms of obesity. Or rather, along with the other factors, we are also competing with them with obesity. So, if you see the causes of obesity, we all know there are individual factors and environmental factors. So, we as doctors probably can control the individual factors, whereas environmental factors are something which have to be also done in parallel with the government or the public authorities. So this is one good article published in the American Journal of Gastroenterology in 2020, where they have followed a huge set of population of around 1,75,000, and they have categorized them into BMI, like a normal weight, overweight, and obese. And out of the obese population, around 27,000, the cancer diagnosis has been predicted. I mean, the diagnosis of cancer in obese has been significantly more. And by predicted BMI at 3 years, this is what has been described. So less than 1% of these huge cohort of population either took some medications or came into your hands to get a bariatric surgery done, which is really alarming. And that too, mind you, this is a Western population. So even in them, it has not taken a major leap of conversion into something for treating obesity. So obesity is underdiagnosed and undertreated. That is what it is. It's like, the tip of the iceberg is what we are seeing, but there's a lot underneath which hasn't been explored. So if you see the pandemics from past 3-4 years, we all concentrated on the COVID pandemic, but parallelly because of COVID and then being less, momentum has been less, and when working from home, the obesity, diabetes, and NAFLD or NASH or fatty liver has equally increased. So if you see any obese person who comes to your clinic, so you ask them, you advise them surgery as bariatric surgeons, 98%, 99% refuse surgery. Go back, they look for some magic solutions, keto diet, Atkins diet, that diet, this diet. They can't succeed. They lose confidence and they keep on eating again, saying, "Wo hoga dekha jayega." And then they regain weight. Again, they lose some dieting. So it's a vicious circle. So this is one elegant paper in New England Journal of Medicine, published in 2017, where they have found that they followed a cohort of population doing a lifestyle modification and pharmacotherapy in the form of this liraglutide or this phentermine topiramate, and less than 10% achieved success with pharmacotherapy and lifestyle modification. That is something very alarming, and that too, it's been published in the most prestigious journal, the NEJR. So you are all masters in this. The metabolic surgery is effective, and there is no second thought in that. It's been established beyond doubt in literature. And if you see the results, 37% and 42% with sleeve gastrectomy and Roux-en-Y bypass. And of course, now the OAGB, what you guys commonly do. But if you come to bariatric endoscopy, like our orthopedic and cardiology colleagues, where they have mastered in arthroscopy and angioplasty, we as surgeons or gastroenterologists should have this bariatric endoscopy as a bridge between exercise, lifestyle modification, pharmacotherapy, and the bariatric surgery. So this is one very good paper published recently in the Nature 2022. If you see the people who are going for this pharmacotherapy and lifestyle modification, and people who are going for bariatric surgery. There is a huge vacuum or a lull in between. And this is a place where we strongly believe in the next decade or two, endoscopic therapies for bariatric endoscopy are going to come into the picture. So now this is something which we all should advocate our these patients in the population, that rule of 10. If you inculcate into their mind that, look, 10% weight loss is good enough for you to have a positive effect. That is something which will be an easy take home message for patients who come to you with obesity. Because if you lose 10%, you will have a positive effect on your hypertension, diabetes, insulin resistance, hyperlipidemia, then also to prevent certain obesity-related cancers, especially bony abnormalities, osteoarthritis, obstructive sleep apnea, then also increase in the positive energy levels and also overcoming the sexual dysfunction or impotency, what we commonly see in obese people. So if you see the bariatric endoscopy in 2023, it is divided primarily into gastric space-occupying devices, endoscopic suture gastroplasties, endoscopic bypass, that is duodenal bypass liners, and of course, bariatric endoscopy is an established role for patients who have got post-bariatric surgery complications like, GE junction leaks, fistulas, so on and so forth. I'll come to that. If you see the EBMT, what we call endoscopic bariatric and metabolic therapies, you have the gastric and the small bowel. Gastric, you have the balloons and gastroplasties. Small bowel, you have the bypass liners, then ablative techniques in duodenum called duodenal because of resurfacing, and so on and so forth. So what happens primarily is when you do something at the stomach level, there will be weight loss with indirect effect on the metabolic effects, metabolic component. Whereas if you do something in the small bowel, they will have metabolic effects independent of weight loss, but there will be some weight loss as an adjunct. So if you see the interventions in stomach, as I told you, the balloons and gastroplasties or the suturing techniques. So the intragastric balloon, I think I don't have to really show, I'll just run through. So this is an Orbera balloon which is being used commonly. Many people in the audience also must have had an experience. It's an OPD-based procedure done with a simple upper GI scope. As you see here, the balloon is inserted beyond the GE junction, and once it goes into the stomach under vision, we are going to inflate the balloon with methylene blue and saline mixed up to 400 to 450 because that is what Indian stomachs tolerate well. And the balloon, what I'm showing you is called the Orbera balloon from Apollo Endosurgery, which is a fixed balloon. And we have a balloon now for the half-life of 5 days. Earlier it used to be only 6 months. So this is the way you inflate the balloon and then keep the balloon inside and then pull the tag out and leave it there. So this will exactly cause volume restriction so that the patient will eat less diet and thereby using around 10 to 12% weight loss. So we have the the air-filled balloons and the liquid-filled balloons. What we commonly use in India or available in India are the liquid-filled balloons. And the literature shows around 10 to 12% weight loss, total body weight loss. And as I told you, Orbera is the one which I showed you. Then you have the adjustable sparse gastric balloon, which also has been quite commonly used. Then there are other balloons, but not available widely in India. And if you see the data pertaining to intragastric balloons, as I've told you, there will be a total body weight loss of about 15 to 18% at 6 months. And of course, there is a 12-month data of Orbera, but adjustable balloon sparse has got a 12-month data, which is showing around 26% excess body weight loss. Whereas the total body weight loss will be around 10 to 12%. So now the advancement in the balloons is something called as ingested balloon, where you don't need an endoscopy to put the balloon. You just have to ingest it like capsule. It goes inside and then it swells upon on its own. And then you put in 3 balloons side by side, and they're about oblong balloons. And this will lead to weight loss. But after 6 months, you put in the endoscope, puncture the balloon, and then take it out. So now the advancement of science happened in such a way that why unnecessarily you have to do a endoscopy. The patient just comes into your clinic, make him swallow the balloon or her swallow the balloon gets inflated, and then after 4 months, the balloon itself gets deflated and disintegrates and then transforms the feces. So sounds very fascinating. As you see this animation here, it's called Elurion balloon, which is available now in India, but it has got around 5 to 7% weight loss, not very much very much beneficial for a good weight loss, but 5 to 7% is what has been studied, not yet FDA approved. But the advantage is you don't need an endoscopy, and probably people who have early BMI, like 30, 31, may benefit, but they don't have a strong literature supporting it. As you see here, it disintegrates after 4 months and then passes on into the feces. So this is what I'm talking about, the adjustable balloon. The advantage of this is it's got a tag which you can take it out whenever you want through the endoscope and the biopsy forceps. And the advantage of this is you can upsize or downsize the balloon. You guys must have heard of the Orbera balloon. Once you put, after 2 to 3 days, the patient gets restless, nausea, vomiting, and you are forced to pull it out. But this balloon has got an advantage of upsizing and downsizing, because if the patient is not tolerating, you can as well remove 60 to 100 ml. And if you feel the patient is not losing weight as desired, after 6 to 8 weeks, you can upsize the balloon by 100 to 150 ml more. You can go up to 900. So that's the advantage of sparse balloon, and there is good literature supporting a landmark article in Lancet on the sparse balloon adjustment after 4 to 6 months. There is profound, robust, more weight loss compared to arm which has got a sham therapy or a lifestyle modification. So we have our own study being performed. We concluded the study and waiting for the results, where we have put this adjustable sparse balloon with obese NAFED patients, and we did a paid liver biopsy using an endoscopic ultrasound pre and post. And summarizing on the balloons, it's got innocuous procedure, and we have weight loss of around 10 to 12% or 15% up to 2.5 years sustained weight loss. So this is again for people, anybody who is in PGs in the audience. This is the AGA technical review of intragastric balloons and management in obesity. So this is again a fascination. This is a gel capsule in which you have to ingest 10 to 15 minutes before the meal. It will get into the stomach and then reacts to the gastric juice, forms a foam kind of thing, so that the volume of stomach reduces, and then the patient will be able to eat only a little quantity. After half an hour to 1 hour, this gel foam will disintegrate and then gets into the small intestine. Of course, this is something which is not very realistic, but it is available at FDA. Coming to the endoluminal restrictive approaches, as I told you, you have lifestyle modification, pharmacotherapy, balloons, and on the other end, you guys, the masters, bariatric surgery. So this unmet gap is supposed to be filled by endoscopic sleeve gastroplasty. There are multiple instruments which have been in the market from past 10, 15 or 2 decades. So currently in vogue are this Apollo Obesity, which is widely available in India. Primary obesity surgery endoluminal pose is available in the US market, and Endomina is available in the European market. This is CE mark, and this is the FDA approved. Let us now concentrate only on the Apollo Obesity, that is the endoscopic sleeve gastroplasty, which we have it in India, and probably many of you want to get a hands on that. I will go to the video specific in the next talk. So what I'm going to analyze now is about the theoretical. So with this endoscopic sleeve gastroplasty technique, we have our own data published in the Journal of Gastroenterology, where we have taken obesity and NAFED or NASH patients, and we have done the assessment of non-invasive fibrosis markers of the hepatic steatosis like ALD, hepatosteatosis index, NFS, FIB score, and APRI. where we have found pre and post ESG after 6 months, there is significant improvement in the parameters with statistical significant value of the B. And about the endoscopic sleep gastroplasty, you as surgeon sitting should be thinking, what's the literature supporting it? This is a landmark article published in Lancet last month about ESG in people with class 1 and class 2 obesity, that is less than 40 BMI. What they did is it's a RCT, randomized controlled trial, where they have taken two arms, one as lifestyle modification and second arm as ESG. And then the results are fascinating and fantastic, where they have found 16 plus minus 7% total body weight loss, and with the excess body weight loss of more than 25% with 77% of the population. And after 52 weeks, the lifestyle modification people didn't lose any weight. They have been crossed over to the ESG arm, where the results are again sustainable with what they had in the control arm. And the results are very promising in this is there is improvement in the diabetes, metabolic syndrome, and hypertension. And as you see, the parameters like HOMA-IR, HbA1c, hepatosteatosis index, CRP and the pro-inflammatory marker, waist-hip ratio, all have found statistical improvement in terms of ESG versus the lifestyle modification arm. Then there is again something which probably will interest you more is the comparison of lab sleep gastrectomy with endoscopic sleep gastroplasty. This is from a Saudi group, the Al-Qathani group, where they have found, as you see on the screen, total body weight loss at 3 years. Obviously, LSG is more robust, more with all due respect for the surgeons. But again, the comorbidities after LSG versus ESG is very less. In fact, you all agree with me about the incidence of GERD post ESG, which is almost 30 to 40%. Whereas in ESG, the GERD, in fact, if at all it is there in an obese person, will come down because of the obesity-related GERD. And we don't, as endoscopists, do the suturing of the fundus because we are blind from this end. So that's the reason why the GE junction is intact and there is no GERD worsening or GERD arising out after the procedure. Adverse events, again, I can authentically say it's almost minimal with ESG except for this nausea, vomiting. Whereas we do find in LSG the G junction leaks and the other things a little more compared to ESG. Revision, again, ESG can always, you do a redo ESG, but LSG revision is a little challenging. But there is something which interests you is the revision of weight regain in LSG patients with ESG. I'll show you in a short while. So now you can, the next question which crops up in your mind is what's a long-term sustainable weight loss? So there is data on that. The Spanish group has analyzed at 2 years and the New York US group at 5 years, where they have found the sustainability of total body weight loss up to 15% and 14% at the end of 2, 3, and 5 years. Just a brief note on primary surgery and endoluminal obesity. This is again a different device, but the Apollo endosurgery requires a double channel scope, whereas this requires a pediatric scope, and it's a different platform of again the suturing the stomach in a similar manner. And there is data on this as well. Now there is something called as pose 2, that is the distal pose, which is currently in vogue in America. So this is again the trial which has been done on pose. By and large, what we have to go over is there is around 12% weight loss at the end of 15 months with this pose. This again endominal. So that difference between this and the last two, what I have shown is this is again a suturing platform, but all you need is a simple upper GI scope with this suturing platform, and this is again a kind of suturing where you do the suture like this, where you pull the mucosa and then tie a knot and continue the suturing from the incision of stomach up the GE junction. This is again not available in India, but we had a collaborative study done with the European centers where you are doing this ESG like the Spars balloon in obese NAFLD patients and then doing a paid US liver biopsy. So this is something what I am talking about. I just skip this because I'll come into the next talk. So the data on ESG is by and large around 50 to 20% weight loss. And as I told you, we had a follow-up data up to 5 years. So this is there are again few papers comparing ESG versus LSG. As I told you, up to class 2 obesity, it's equally efficacious with of course less morbidities compared to LSG. Again, learning curve is very important. As you learn the saline, this also needs a learning curve. You compulsory have to have a hands-on technique on animal model and then a proctorship in presence of an bariatric endoscopist and you respect to you with initial 2-3 cases, then you can take on. But the literature says you need at least 35 cases. But my experience is you need maximum of 15 to 20 cases to cross the learning curve. We, in fact, at the AAG do a monthly hands-on course on this ESG as a regular monthly program. So then this is something a little advanced, but I don't want to bore you. This is also a kind of a strand which we are working on with the Michigan group. This is at the main side still. R&D is going on where we put a esophageal metal stent kind of thing, and the gastric area is occupied with a stud like this, which will give satiety at the cardia, thereby leading to decrease in the appetite. I can skip these slides because it might not be very interesting. So one fascination as a next generation, I'm not talking it is in the pipeline, it's already in the market, but not commercialized. Why doing all these things, coming all the way and then asking Dr. Rakesh Kalapala to teach about ESG? So there is something which is called a motorized endoscopic sleeve gastroplasty. It's called endozip, where it has got a motor. All you have to do is put in this along with your scope inside your stomach. It itself will grab the mucosa and then suture it. And it's an Israel-based company which has done the first in human trials on 10 people and also published. And trust me, it's soon going to be in the market in the next 2-3 years. It's not a long way to go. As you see here, it approximates the stomach and then it starts suturing. So that's what is science is evoluting into. So the third part of my talk in this talk is we all look forward in India, in Asia, in the Western world, diabetes, obesity with fatty liver. Can we do anything on this in terms of bariatric endoscopy? So the biggest challenge we face day in, day out is type 2 diabetes. So here I come into a little basics of physiology. So what we all should now put in our thoughts and mind is duodenum is the epicenter for metabolic control. It's not the pancreas, it's not the brain. We all know that pancreas is the main organ for glucose metabolism, but now it's no more the main organ. Whatever is happening in your insulin axis or the diabetes is the metabolic control is all in the first part of the duodenum. I'll tell you why. See, you eat a nutritious meal and you have the incretins and anti-incretins on the brush border of the duodenum. When you eat a good, nutritious, hygienic or a low-calorie meal, then these incretins and anti-incretins will balance the duodenal mucosal lining and release of this, and that leads to euglycemia. But when you have sumptuous, heavy meal, what probably Dr. Bhalla must have given you the lunch. So what happens then is there will be an imbalance between incretins and anti-incretins, and that's a basis for insulin resistance leading to hyperglycemia, hyperlipidemia, and NASH. So the main physiology behind diabetes is this imbalance between incretins and anti-incretins. So that's where the interventions at the small bowel level, the alike of RYGB, Roux-en-Y bypass started, and people started working on that. So this is again your RYGB, which we all know, a fantastic surgery for diabetes and obesity, which is now being replaced by one anastomosis bypass, OAGB, gastric bypass. So we are not saying that there is an alternative for surgery, but there are things which we are really working upon to find alternative in surgery, because RYGB has got its own, it's a major surgery with its own complications like dumping syndrome and vitamin deficiencies. So there is a device called endo barrier, which was actually approved by FDA but took a backseat, where it is a duodenal bypass liver, which prevents the absorption of nutrients in the first part of the duodenum. And it has taken a very positive big leap. But unfortunately, because of these barbs, what you see on the screen, there were cases of liver abscess. And, there was withdrawn, unfortunately, from the market. But the device has shown an improvement of HbA1c by 1 to 1.3%. And because, as I told you, there are serious adverse events, the FDA has withdrawn from the market. With this idea in the back of the mind, we at AAG started working on a device called EndoSleeve. This is basically a pyloroduodenal stent with a poly-Teflon coated sheath of 60 centimeters length covering the first part of the duodenum. So what it exactly does is, as you see here, this is a very simple technique of using the upper GI scope and then pushing in this device along with the upper GI scope. And all you need to do is you deploy a pyloroduodenal pipeline stent with a sheath which covers the first part of duodenum made of PTFE. And then you leave it like that. It hardly takes 15 to 20 minutes to do this procedure. And as you see here, this is, I'll just show you how it looks when you do in the humans. So as you see, the capsule goes in and then it will deploy the stent on the duodenal end first and then the gastric end. As you see on the screen, this is the PTFE sheath which coats the duodenal mucosa and prevents absorption of nutrients. It's same as easy as that is to deploy. It's same as it is easy to retrieve also. You have a lasso here, you catch the lasso and then pull the stent assembly out. Then the stent will collapse and gets into the capsule, and then you just have to pull the sheath out. So this is the human model what we have done. You catch the sheath lasso, pull it a little hard, this entire assembly will collapse, gets into this capsule, and then you pull out the sheath. So this is something very fascinating where we have found improvement in HbA1c levels by 1.8 to 2% with weight loss of about 10 to 12%. But it's not as rosy as it looks. We had these migration issues because internal migration, because stomach is, the pyloroduodenal part is the most robust valvular mechanism in the body. And because of these movements, the stent started chinking and then getting into the distal small bone. So then we went back to bedside, did some more animal experiments in Minneapolis, and then we came up with measurement of the normal pyloric sphincter physiology using a endo flip, it is a functional luminal imaging probe. And then we went back to bedside. Because of this COVID, there was a little lull, but we came up with a T-tag or a stent fixer so that it will prevent the migration of stent into the duodenum. The other one is the ablative therapy, which is you all must have heard of or read in the papers and articles, the duodenal mucosal resurfacing. So you ablate the root of duodenum using a hot water or electroporation or electrical stimulation, and that will kill the enterochromaffin cells and it improves the GLP-1 analog and GIP-1 hormone secretions. So the one which is in the market is the duodenal mucosal resurfacing, where you put in a catheter and then ablate the duodenal mucosa by inflating this balloon and pushing in hot water of 90 degrees centigrade, which will char the mucosa and then ablate the mucosa. So this is how it looks. You start from proximal to the papilla and then go up to the first D1 post pyloric area. And as you see here, once you do the mucosal resurfacing, this is how the deodorant mucosa appears. And as you see, after the ablation, within 3 months, the mucosa gets back to normal. And all you need to do is lift the mucosa with saline, ablate, then come back proximally, do the serial ablations. And this is not again hypothetical or theoretical. There are published randomized controlled trials on this, in that too in a peer-reviewed journal like Gut. In 2020, Gut has published this, where they have found improvement in HbA1c levels, improvement in the ALT, AST levels, and also the cardio-metabolic parameters. So that's about the duodenal nipples resurfacing. But because you're putting in hot water, a little crude technique, people started working on, doing a electroporation, which is again a different type of ablative technique, but there is not enough literature on this. Then another, which is a fascinating, is, you guys do the ileal interposition. So we as endoscopy started working on doing jejunal-ileal bypass using endoluminal magnets. What you need to do is, from the oral end, you pass in endoscope, and from the aboral end, the colonoscope. These two will reciprocate. There are octagonal magnets which you place at the jejunal-ileal interposition level. And as you see here, by day 5, 6, it creates a natural fistulous communication, whereby the food directly from jejunal goes into the ileal, which is like your ileal interposition surgery, but there's not much data on that. I'll skip this Valentix. And by summarizing on duodenal bypass liners, the main aim, as I told you, is to improve the diabetes and indirectly the weight loss, and more importantly, is improvement in the cardiometabolic parameters. And this is something which is very fascinating in the market after the level of oral semaglutide Indian market. So if you do bariatric endoscopy, be it a balloon or endoscopic sleeve gastroplasty, and then add on this GLP-1 analogs like liraglutide or semaglutide, especially in people who are binge eaters, that will have a robust weight loss compared to doing only the precision. So just to summarize, gastric EBMTs, small bowel EBMTs, I told you the balloons and the gastroplasties, then you have the duodenal bypass liners and the ablative techniques. So endobariatrics, I strongly believe, is if you combine the stomach and small bowel with the pharmacotherapy, that is the GLP-1 analogs, this is something, I don't say it will replace surgery, but it is going to be a bridge between surgery and lifestyle modification, in especially people who have got, BMI between 30 to 35 or 40. Then this is not again a fantasy or a fascination. Robotic endobariatrics is already started. There is a first human trial of 5 patients which happened in Italy with my good friend Ivo Boscowski. And I think that also is going to be soon in the armamentarium of the endoscopists. So as we all know, friends, necessity is the mother of invention. And we as surgeons, physicians, scientists are trying our best to overcome this pandemic of obesity and diabetes in our own ways and means. And let's hope that for the future generations, we give a deflated therapy which can be a minimally invasive or a non-invasive or an invasive. But again, all said and done, it's not a single man show. You need a team like this. You as bariatric surgeons also should advocate this wherever you are going to practice, that it should be a team of bariatric endoscopy, bariatric surgery, nutritionist, very, very keen and important person in your team, the endocrinologist, cardiologist, orthopedics, and all the referral doctors will refer to you, because that's more important. Because no obese person will come to you at clinic and say, "Doc, I'm obese, you treat me," unless until he is pushed by somebody from your fraternity.